Good evening, everybody, and I would like to welcome all of you to this edition of Diabetes Bytes. We have been running this entire campaign on type 1 diabetes, which we feel is a very important initiative from RSSDI, and we have been bringing for the last couple of days stalwarts in diabetes to this program. Uh, Today we have three stalwarts who have really been luminaries in diabetes and have done some great work about type 1 diabetes. So I'm going to introduce, and I don't waste too much of time with introductions, but I want to get really to the meat of the talk as to what we really feel about type 1 diabetes in India. And I'm going to point a lot of questions to these stalwarts and get their opinions. It's my privilege and honor to introduce Dr. V. Mohan. He's the chairman of the Dr. Mohan's Diabetes Specialty Center, and he's the president of Madras Diabetes Research Foundation in Chennai. His main research interests are on epidemiology of diabetes and its complications, genomics of diabetes, fibrocalculus, pancreatic diabetes, and precision diabetes. He's been conferred fellowships from all the four Royal College of Physicians and the three Science Academies of India, including fellowship of the Indian National Science Academy. He's received numerous awards, has almost about 1,300 and odd publications in peer-reviewed journals, including 878 original articles, 170 chapters in various textbooks in diabetes and internal medicine, and his work has received over 140,000 citations, which is a huge number and a pride for India. And has in 2012, Dr. Mohan was awarded the Padma Shri from the Government of India, and he's authored the book Making Excellence a Habit: The Secret to Building a World-Class Healthcare System in India. Welcome to the show, Dr. Mohan.
Thank you, Sanjay.
Yeah. It's also my proud privilege to introduce Dr. Nikhil Tandon. Dr. Nikhil Tandon is the professor and head of the Department of Endocrinology at the AIIMS, New Delhi, one of the most premier institutions in India. His research interest is, of course, diabetes of the young. He chairs the technical coordinating unit of the ICMR Young Diabetes Registry. He's got more than 425 publications to his name. He's a former president of the Endocrine Society of India, Indian Society for Bone and Mineral Research, and the RSSDI Delhi chapter. Fellowship, he has the fellowship of the National Academy of Medical Sciences, Indian Academy of Science, and National Academy of Science. And he's been conferred the Padma Shri and Dr. B.C. Roy Award. So welcome to the show, Dr. Nikhil Tandon. It's a privilege for us to have you in with this show. I'm also going to invite Dr. Alok Gupta. He's been with us in numerous other programs, and it's always a pleasure to hear him. He's made time to join us from UK, and I'm sure we'll be looking forward to an interaction with you, Dr. Alok. He's, of course, got a huge presence in diabetes, and as I see his CV, I don't know where I should start and end because he's got so many numerous publications and citations and awards to his credit. But he's a senior consultant pediatrician and a diabetologist. He's a clinical director in the Department of Pediatrics at the Dartford and Gravesham NHS Trust. I'm just going to read out the excerpts from his huge, accomplishments. So he's the clinical director of pediatrics at the DVH since March 2015. He's the trust lead for pediatric diabetes services since 2003. He's been the clinical RCCH.
Sanjay, I think it's okay. I think one other thing I can say is we are leading on clinical networks for diabetes in children and young people. And that's something very significantly different and unique when we compare the world versus UK clinical networks, which I lead on in southeastern London. But that rest I think is okay. Thank you.
Thank you very much for guiding me. But I think I'm going to move on to the show, and I'm sure we're going to have a lot of interesting interaction, and I'm going to point questions to all our three stalwarts. So let me begin my first question and allow any one of you to take this question. That how do you perceive type 1 diabetes care in India today? So I'm going to ask Dr. Nikhil Tandon as well as Dr. Mohan to give their idea about this. That how do you look at type 1 diabetes care in our country?
Probably Nikhil can answer because he is heading the ICMR Young Diabetic Registry, so probably he can go first. Nikhil, you're muted.
Yeah, I'm fine. Thank you. So the problem of type 1 diabetes, if you look at it, by our sheer population size, we are effectively the largest number of people with type 1 diabetes anywhere in the world. And I think we need to understand that when a lot of us who are on the panel were maybe undergraduates in medicine, it was not considered to be a common disease. And the reason perhaps was that it was unrecognized, undertreated, and therefore children died before they were diagnosed. And I think I want to start on this rather somber note because it has relevance to the rest of today's conversation also. That an undiagnosed, untreated type 1 diabetes can actually result in the death of an individual. So the numbers we see are that at the moment the Young Diabetes Registry, which as just mentioned, supported by the Indian Council of Medical Research, looking at people who are diagnosed below the age of 20 years, about 75 to 80% of that population is type 1 diabetes. And that means it's a sizable number. It is unfortunately very often presents in catastrophic ways, with people presenting in a life-threatening acute emergency called diabetic ketoacidosis, and or other reasons for hospitalization, which, if not identified soon enough, can result in fatality. I'm going to just stop here now because I just want this message to go through very clearly at this point in time, and then maybe add on to this later on. Thank you.
Very well said, and I think your points are absolutely required to be put across. I'm going to ask Dr. Mohan, and then I'll move on to Dr. Alok, that we have anybody who comes to, let's say, young onset diabetes, and there's a whole spectrum there we see in diagnosis of diabetes, and you've written a paper, very well written paper on this. So if suppose a 16-year-old or 15-year-old comes to you, what are your different ideas that you would put, and how would you guide somebody that how would you by process of elimination decide what kind of a diabetes this child has?
Thank you, Sanjay. It's very interesting because in South Asia in general and India in particular, there are a variety of types of diabetes that we see at younger age groups. And it all depends on the age at which the diabetes is diagnosed. And it's quite specific for that. We've seen this in the Young Diabetes Registry. We've seen it in other places. For example, we call the Young Diabetes Registry, as far as ICMR is concerned, which Dr. Nikhil Tandon just mentioned, with onset below 25 years. But if you go to say 20 years, or that is the above adolescent period and early adulthood, it's mostly type 2, although you can get type 1 at that age. If you now switch and go to say below 10 years, almost always it is type 1 diabetes, except for a very small number of children who get it below 6 months of age. That is the newborn children between birth and 6 months of age. There we have an entity called as neonatal diabetes. And those children, about half of them can be controlled with tablets. They may not have type 1 diabetes. They have a genetic defect. And it's very important to identify those children. Otherwise, we'll keep treating them as type 1 diabetes. And the numbers are not small. We've got a few hundred children like that in India already. Even I have seen a few hundred children already with that. So if you leave that below 6 months of age and go between 6 months to say 10 years of age, almost 90-95% will be type 1 diabetes. Occasionally you may get a MODY, or occasionally you may get a type 2 diabetes, but by default it will be type 1 diabetes. Now if you go from 10 years to say 15 years, it's still predominantly type 1, but because adolescence is setting in, you will get a few type 2s coming in at that particular stage, and you might get this fibrocalcific pancreatic diabetes, stones in the pancreas, MODY, maturity onset diabetes of the young, which is a monogenic form of diabetes, can be usually treated with tablets. All those will come in, but they are rare, and type 1 is the predominant one. But the moment you cross the 15 years, type 1's the big peak that we are seeing will slowly start declining, and in our country especially, type 2 then takes off. And because the children are getting obese, more and more obese, there's a strong family history, they have insulin resistance, they have acanthosis nigricans, and that becomes slowly, that starts becoming more common. When you cross 20 years of age, then type 2 really begins to take off in a country. And after 25, of course, it's predominantly type 2, although you do get all these varieties of diabetes. So when you see a young person, in our mind, we have to keep in mind that occasionally it may not be type 1, because if you don't do that, you'll treat everyone as type 1. But at the same time, the index of suspicion should be there. But at the same time, remember that type 1 is the commonest. And therefore, while all these other forms can be thought of, you should not forget that type 1, which if you don't give insulin, the child will die. That type of diabetes you should never forget. And therefore, some basic investigations to see whether there is ketosis, whether there's a family history, whether there's C-peptide. There are 1 or 2 antibodies that you can do, GAD antibody or zinc transporter IA2. Quickly you can find out, because it's a once in a lifetime thing. If you have the facilities, you can do that. At least otherwise, to give, see whether insulin requirement is there, what is the type of presentation, was it very acute? With all that, you should be able to roughly sort out the type of diabetes. And it's very interesting that while the majority of patients in the young diabetes registry is type 1, we do see the other forms of diabetes as well.
So, Dr. Alok, I'm going to move on to you, and I'm asking you a very relevant question to our clinical practitioners. We are a resource crunch. Obviously, a spectrum of people that we've got, not everybody can afford all the investigation that we routinely in an academic sphere talk about, that you should do all this list of investigations. Versus, in UK, you have a lot of insurance cover for these people, and you can do all the kinds of investigations that you need. To our doctors over here, can you tell us what minimalistic investigations that you need to do to diagnose type 1 and monitor them across, when we are taking care of them? So what is the absolute required investigation that you should do, and what are the optional investigations that you can?
Thanks, Sanjay. But I think before I move on to that question, I think I would like to echo what Dr. Tandon and what Dr. Mohan said. Completely, absolutely true, even for country like here. In terms of really, this is something I've done for last nearly 20 years, DK prevention campaign in primary care and public in the local area, in order to prevent DK, which is diabetic ketoacidosis, where children can become quite unwell with, I think, with low pH or acid pH in the blood, the complications of type 1. So simple message to public and to the primary healthcare physicians or secondary care is, as soon as you suspect, I think, diabetes in any young child up to the age of 15, even 16, in UK, the cutoff is around 16, we presume it's type 1 until proved otherwise, because of safety, because of to prevent diabetic ketoacidosis and prevent mortality, because 40% population can still die out of DK because of cerebral edema. So we don't want to delay any diagnosis. So the bottom line is, the rule of thumb is, it's a type 1 until proved otherwise. And insulin is a treatment for type 1 and type 2 begin with. So simple message again to primary care physicians or secondary care consultants or clinicians is, you don't need to do many tests. Simple urine test or a blood test with, I think, blood sugar and the ketone bodies to make diagnosis. So we don't make this diagnosis very investigation heavy. But for academic reasons, we can always do antibodies and things, really, but it's not required in the light of when it comes to diagnosis. So I think this is a very, very important, powerful message we should send across the countries or internationally. You should not delay the diagnosis of diabetes because of investigations, and never miss type 1, and never allow type 1 to present as a DKA. And we managed to bring our DK incidence significantly down in the local region, which is southeastern London. And that's a really important message. I hope that really answers your question. I don't want hundreds of tests and delay the diagnosis. It's a very simple maintenance condition with diagnosis with blood sugar, and that's what we need day on day in terms of monitoring about type 1. Thank you.
Thank you. Dr. Mohan, you have done extensive work, and you have, of course, a lot of population of type 1 under your care. When somebody comes to, what is the minimalistic investigation that you advocate in your practice?
Yeah. So, I mean, I agree with Alok. See, while the ideal situation is there, you cannot have ideal. The world is not ideal, and so you cannot have everything for everyone. But there are simple things that we can do. For example, with a pen and paper, If you just start taking a family history of diabetes, in type 1 diabetes, it's very rare for the parents to have diabetes. And I'll tell you why. Because when the child is, say, 8 years old or 10 years old, the parents are probably 25, 30 years old. At that time, type 2 diabetes is not that common in our country. It's only after 30, 40 that you really get. You do have a little bit of diabetes there. So by the time the child presents, when it's, say, 3 years old, 2 years old, the parents will probably not have diabetes. Whereas if there is type 2 diabetes, which is going to come at that age, without the parents having usually both the parents, for the child to get it at that age, there must be obesity and there must be diabetes in both the parents. So even just drawing a simple pedigree chart, if you see that there's no diabetes in the family, it's type 1. It cannot have type 2, you cannot have MODY, you cannot have anything like that. FCPD is a rare disease which presents with abdominal pain, which you have for a decade before you get the diabetes. So you need not even consider it in the differential diagnosis unless it's a very thin child and so on. They're extremely rare and the incidence is actually going down. So unless proven otherwise, it is type 1 diabetes. The type of presentation will make it very simple. As Alok said, somebody is presenting with weight loss, vomiting, and urine ketones and blood ketones are positive. What are the diagnoses is there? There's no other diagnosis of except type 1 diabetes. So insulin requirement from the beginning, and the moment you give insulin, the child recovers. This is a dramatic thing which doesn't occur so dramatically with type 2 and MODY and so on. So there are clinical indicators which will tell us whether it is type 1. So unless proved otherwise, it is type 1. If you don't follow that and you think it's type 2, maybe we'll try tablets for some time, the child may die, may go into ketosis and die. So unless you have enough reason to suspect it's not type 1, every child with diabetes has type 1 unless proven otherwise. And you will get these all these indicators. So these are the minimistic. See, first of all, for presentation, HbA1c, okay? In a type 1 patient, the HbA1c will be very high. HbA1c you should do because you'll know how long the child had it and you'll also know how high. If you have HbA1c of 13, 14, 15, you don't normally get that in a MODY. In a type 2 also, it's very unusual to get that. If you have blood sugars of 400, 500, it's very unusual for a type 2 to get that kind of reading. So looking at the clinical presentation, the urine glucose, the blood ketones, urine ketones, HbA1c, at least this minimal thing will, and weight loss and acute onset with polyuria, polydipsia, all that is very typical of type 1. Although there's a lot of overlap. I mean, there is type 1.5, type 2s can present with that if they are undiagnosed. But let's not get into the rarer variant. In a classical, the whole discussion today is we should not miss a child with type 1. No child should die because of wrong diagnosis. As Nikhil said, many years ago when we were students and all that, we were not seeing so many. One wonders whether they were all dying in the in the village. Where the child goes into coma, they'll think it's TB, meningitis or something and start treating. They don't even do a sometimes they do a CSF sugar and find the CSF sugar is 300 or 400. Then only they diagnose, oh, this is diabetic ketosis. Many don't even do that. They don't even do that. So we would have missed a lot of cases. Today, the index of suspicion is high. So our job as endocrinologists, diabetologists is to educate everyone so that any child coming in with any disease, just do a blood sugar. Just like you check the fever and you check temperature or you check weight and pulse and all that. Check on glucose, nothing wrong. It takes you 5 seconds to get a glucose done. Even a glucometer reading is sufficient. If it's 80 or 70 or something, you ruled out diabetes straight away. So I think the index of suspicion should be high.
I think if I may make a comment at this point, just to really add on, I think at least being a children's clinician, I think obviously not talking about somebody who's 25 or 30 or 40-year-old, we have to have all kind of possibility in mind, but up to 12, 15, I think, as we said, I think is very, very high probability is a type 1. And I think when we started talking about investigations, we do confuse, I think, other colleagues or clinicians in the country, because then they start thinking, oh, somebody said could be type 2, somebody said could be MODY, somebody said something else. I want really that confusion to be removed, I think, at least from children population and young people population. The simple message is, if their child has got a drinking too much, passing too much, losing weight, it's a diabetes. It's a no-brainer. Simple tests like blood sugar or blood ketones or even urine. I removed that even blood thing burden from primary care physician. Can we do urine, please? And then you refer on to a specialist center or a specialist who can deal with it. I think that has to go, I think, from this forum. we make it really quite heavy and burden to say do hundreds of tests, oral glucose tolerance test. We are confusing that population very badly. So I think for children's point of view, I'm really concerned we talk about too much investigations, at least for diagnosis. HUNC fine, follow-up is fine. But simple is, can you suspect that situation and can you make a simple diagnosis with a simple test? That's what I think we are expecting them to do. Thank you.
Dr. Nikhil wants to say something, please.
I'm sorry, I don't want to labor a point beyond, but I think there is absolutely no urgency in looking at the various differential diagnoses when you see the patient for the first time. When you see the patient for the first time, what do you want? Do they have diabetes or they don't have diabetes, right? And even if you are misdiagnosing type 1 diabetes and giving insulin unnecessarily to a few on that first clinic visit, you can always rectify it down the line. If you miss giving insulin on the first visit, you may not have a second chance to rectify. I mean, I think the message has to be very, very simple and crisp that yes, I may be wrong. This person may not have type 1 diabetes and I've given them insulin. I understand all the problems associated with that, but I will still get a second chance to correct that. But if I don't give insulin on that first time and it was really a type 1 and it was a judgment error, I may not and the child may die. And that's all. I mean, we can always work our way through in follow-up visits. And truly, I mean, we can have a differential diagnosis as time passes on. Everybody can go wrong once in a while, but you've got to err on the side of absolute safety for your patient.
Yeah, Dr. Mohan, please go ahead. Yeah.
No, I wanted to agree with both of them and say that even if it is type 2, let us say it is type 2, okay? Type 2s don't present early. Why would they present early? They won't have any symptoms, unlike type 1, which is an acute onset. Within a week, the child can become very sick. Type 2s would have missed for 6 months, 1 year, and only when they become sick, they come to the doctor. So you can have very high sugars at that time. You can have a little ketones at that time. We have seen in our registry that even type 2s have, of course, they may not have frank ketoacidosis. Even that you can have. If they're neglected long enough, they have an infection or something, even that they can have. So the absolute treatment at that time, even if it is type 2, would be insulin only. Only later on, the child will behave differently. Suddenly the insulin requirement comes down. Suddenly we find that, oh, this child has a family history. Can it be something else? Can we think of something else? The parents are always asking, is it only in type 1? Is there something else? Then we start looking for other, oh, there is a little bit of acanthus nigricans. This is something else. So in that first instance, saving the child is most important. At that time, if you say, no, it could be type 2 and you try metformin or something, and the next week the child dies due to ketoacidosis, we have actually killed the child. So we have to be very, very careful because the only chance we have is to save that child. So absolutely, it doesn't matter even if it's MODI or anything, FCPD. So what? You give insulin to them, nothing's going to happen to them. So even the neonatals, see, once they're diagnosed, even before 6 months of age, just because they were diagnosed before 6 months of age, we don't do first genetic testing, wait for that result, and then start. Child may die because there is type 1 diabetes even at that age. So first thing is to do is to start insulin. Then having done all that, is there a chance that this child has something else? Then we say, oh, the genetic tests are come negative, this is type 1 only, we continue. If we find, oh, okay, this child has something else, then we can think of whether sulfonylurea can be given or something like that. So the first treatment is insulin only. I entirely agree.
Okay, Nikhil, I'm going to point this question to you, and it's a very important question, and I may combine it with Hindi because for the sake of, lay people who are listening on to this program. अक्सर ऐसा होता है कि जब किसी के घर में टाइप 1 डायबिटीज डायग्नोस होता है, यंग चिल्ड्रन 8 साल 10 साल के बच्चे होते हैं, तो उनकी फैमिली एकदम से वो एक ट्रोमा में आ जाती है कि उनको क्या हो गया है इस घर में. I mean, the whole world gets crashing. Can you give 10 key messages to the parents of a type 1 child that will comfort them and give them hope that the child can do better in future?
Well, I think this is a very, very important question, and I would really want to recruit my co-panelists to reach up to 10 key messages. I may not be able to. but I
I
think
can
you're
help
right.
you.
And
I
say it in both English and Hindi, so I'll know what
Yeah.
you have said.
So Dr. Mohan, the question was that when an 8-year-old child develops type 1, the world of the family comes crashing down, really. And what can we do in terms of giving them key messages that there is an element of reassurance and we can stabilize. So, Sanjay, I think that's a very important. That is the real question, and that is a question which also sends a family running helter skelter to look at multiple solutions which they feel are less intrusive, less invasive, and less traumatic for their child. And looking at it from their perspective, I understand it absolutely, and I would not want to be judgmental about it at all. It was the immediate response of any family. How do you help? Right? I think what you've got to say is that actually it is perhaps the commonest chronic disease of childhood, right? So you are not alone. There is a world out there which is also facing the same challenges and successfully facing those challenges. So you will get support. Number one. Number two, we understand a fair bit about the disease, right? And therefore, we have solutions and therapies for a large part of this. And so you must feel reassured that A, we can diagnose, B, we understand what's required, and C, we have those therapies available and we will give them to you. Number three, we also understand your concern about insulin injections. We share your concerns. We understand why you would be concerned. And we will also remember one thing, that if we ever find that there are non injectable remedies, we will be the first ones to come and tell you about it, because it is not in our advantage to unnecessarily treat a child with an injectable form of therapy. We will be there. So assume and take it for granted that we will tell you. Fourthly, that there will be several people who are well wishers. I'm not questioning their intention at all, who are well wishers, who will look at your anguish and torment and say, let me take you to A, B, or C, who can give you an alternative, non injectable form of therapy. I understand you would be tempted to do that. If possible, believe in what I'm saying, don't even try it, right? If you don't believe in me, then my plea to you is, if you want to try something, add it on to their insulin so that at least the basic treatment continues. And if that medicine is so wonderful, you will require less and less insulin over a period of time, and we can decide. But for that, even if you're adding something new on top of insulin, you need to monitor sugar. There is no other way of doing this except for monitoring sugar. So I think I've done 5. One more thing is, remember that we want you as much as you want and your child wants, so the child runs a normal life. We will encourage that, we will support that, and we will do everything possible that they eat, drink, play, study, and do everything that their colleagues and peers do. We don't want this child to be treated as a special child. We want to look after him. We want to take care and precautions, but we will do whatever it is and whatever power is in us to ensure that your child remains as normal and as similar to all his or her peers. I think I might be running out of things, and I can see Dr. Mohan is there.
We all can chip
All is
in.
mailing out.
So I
Okay,
can continue with number 6, 7. So the sixth one is that many of us have been in practice for decades. I have been almost for 5 decades now. So I have seen children who were treated by my father, who was also a diabetes specialist, who were then 5, 10 years old now, were still alive. And I've just collected a series, I'm just publishing it, of people who have finished 50 years with type 1 diabetes. We have collected from all over. And so while the Jocelyn medalists report was published from the US and from UK, they think that in India it doesn't happen. But in India also, we have got people who have finished 50, 60 years with type 1 diabetes. So they've lived their full span of life. India's lifespan is only 67 years for males and 69 years for female. And here we are talking about children who have developed type 1 diabetes now living to 70, 75 years. Some have become grandparents and so on. So long life is possible, but they all took insulin. The next point is that you can also have heroes among type 1 diabetes. So we have Olympic gold medalists like Gary Hall. We have had the Pakistan cricket captain and Wasim Akram, who took 250 wickets before he got type 1 diabetes, 250 wickets after he got type 1 diabetes. We have Nicole Johnson, who became Miss America. We have people in India who are running marathons with type 1 diabetes. We have youngsters with type 1 diabetes who are now maintaining A1Cs much better than mine, and they don't have diabetes. I'm ashamed to say their A1Cs are 5.3 and 5.4, higher than mine. And they're not getting hypoglycemia. They're known how to manage it. Their quality of life is very good. So whatever you want in life to do, many of my doctors who work for me have type 1 diabetes. So they have grown up, I've been treating them, then they've developed type 1 diabetes, and they became diabetologists, they've joined me. And so their whole life. So what is it you want your child to do? You want them to get, to study well, to have a good job? You can do that. You want them to get married, to have children? You can do that. Will their children get diabetes? Very unlikely that the children will get diabetes. Do you have examples of those who have lived their full life with marriage and family and so on? Yes, of course, we have all of that. Can they be very successful in life, and can they, travel? Can they do everything that they want? Yes, they can. Can they take part in sports? Yes, they can. Can they do any other activity that a person without diabetes can do? Yes, they can. So virtually everything you can do. The only bottom line, the underscoring is don't stop insulin. Whoever tells you don't stop insulin, so that particular one alone, all of them whom I described have continued insulin all their life. So if they ask me, have you ever seen one child who has gone off insulin completely? Well, to be honest, I have about 7,000 children. Out of that, I think one has gone off insulin completely. I know for 4-5 years they've gone off. That person went to Dubai, stopped insulin, was taking 3-4 times insulin, and then suddenly one fine day they said remission. I thought it's some 2-3 months time. Then 1 year later they said I'm still off insulin. 2 years later still off insulin. 3-4 years later still off insulin. I don't know if it's really type 1 or had some other type which we were not doing genetic testing and so on. It might have been something else. I don't know. Or it could be a true remission or a true permanent remission. Like in biology, anything can happen. You can have a total cure. So even that is possible. The last point I want to say is, as of now, we don't have a prevention, although that is coming. And as of now, we don't have a cure, but you can have a long life. Over to Alok.
Alok, you wanted to add something to this?
Oh, I think they exhausted the list. I think they've given at least 20 messages, but all lumped together. But my message, I think, just to re-pick on, I think the most important and first top 5 messages would be not to stop insulin. Kabhi band nahi karna. Insulin kabhi band nahi karna. And that's I think the top message we need to convey again, to say you can't afford to stop insulin because it's a life-saving drug. And that's the way I tell my patients and families and other people. It's a life-saving drug, and you can't afford to stop drug just like this. If something alternative comes, you will learn a lot more quickly from all of us. And this is not necessarily just in India or UK, it's international. So they all in the same boat. I think that's the important top 3 messages, to say you can't afford. Rest is absolutely similar to any other person or individual. They have a similar potential, similar quality of life they can lead. They are very loved ones by their parents and family and society. I think people know a lot more about diabetes than other long-term chronic conditions like cystic fibrosis. So system have made a lot of adjustment already. It's not uncommon condition in India to say, what is diabetes? How do I manage? And final thing, maybe, I think Dr. Mohan said about hypos. So maybe only one emergency you get it, which is hypos. should not be worried about it. It's like a feeling hungry. We all like to eat food. And that's the way I think we need to really convey, reassure them. But this should be given a potential where they can achieve the maximum, whatever the potential they have. That system should try to help and support them by doing more. But I think my top message and the last message, not to stop insulin. There may be alternative healers or medications, but they're tried and tested for different kinds of diabetes, not type 1. Maybe for type 2, maybe something else. And one patient where Dr. Mohan said, I think he cured or went into remission. In my case, it was a wrong diagnosis. For a child who had asthma, was treated with steroids and developed steroid responsive hyperglycemia. It took me 6 months with very careful approach to stop insulin because it was never been type 1. I would still say nobody cured diabetes type 1 in the world reliably. I think I'm confident around it. So if somebody says I'm going to cure it with simple pills or tablets, they are really, I think it's either wrong diagnosis or they are really misleading that population, risking that child to die. And that's a really, and it could be really quite significant. I think it could, in the UK, it's a criminal. And I can't really say I can take that information to India, but it could be a criminal. If child dies because lack of insulin, because a doctor or an alternative healer said to stop insulin, something goes wrong, that person would be held to account. That's very clear.
I have actually seen children who have died like that, who were we were giving free treatment. They had all the treatment free insulin was given. So they didn't have any financial burden. We looked after everything. And then the child or the children, in fact, a couple of them, it's happened. They didn't come back the following month. And then we said, why didn't you come? And we are calling the father and saying, why haven't you come for your insulin supplies? Have you gotten somewhere else? And then they start crying. And they say we made a big mistake. And what is this mistake? We were lured away by another alternative practitioner curing, and we thought you can understand our position. But we said, didn't we tell you so many times? No, but doctor, we must understand our position when somebody says, and that person said, just stop insulin, try mine. Within 48 hours, the child went into ketoacidosis. We rushed the child to hospital. Unfortunately, the child died. Now, so we have heard this kind of story. I would say, I mean, if I want to put it very crudely, it's murder. Because when you know that somebody you are intentionally treating a condition which you cannot treat, it's equivalent to murder, because the child is well settled. It's not the child didn't have the diagnosis. Well settled child, you take them away and it's like withdrawing oxygen support. Suppose you cut off oxygen to somebody who's going, now I'm going to cut your oxygen, kill you. That's also murder only. So it's equivalent to that. We must be very, very, very careful about this. And I think somebody also asked that when people say like that, what do you do? All we see in India, it's not criminal in that sense. I don't know what the law says. I would say we should make it a law, but all we can do is to educate people. And then beyond that, if the parents decide to do something with a child, we can't help it. But let it not be said that we did not educate. We should do, and that is why this forum is very important, to educate.
I think, Sanjay, if I just say, I think sometimes it falls back onto all of us. Rather than just saying the third party did this or other people are doing it, somewhere along the line, we need to do a lot more campaigning, lot of publicity, lot of familiarity. Once it becomes a common man person subject to knowledge, you automatically become successful. Like antibiotic, that's a success story. Infection is there, you need an antibiotic. I don't need to go and tell public or other people. So maybe we have done a lot, I think, in the last 20, 30 years in terms of type 1 diabetes or diabetes, but maybe a lot more to be done. That's where this kind of forum and campaign, not just healthcare professionals, but international charity organizations who are active in the country. So I think we need to do global campaign in order to make it work. We have done a lot of work, but not enough. So we can't take responsibility away to say it's nothing to do with us because the people are doing it. But why they are doing it? Because we have not done enough to stop that nonsense. So I think that's where I think my position would be.
Today, I'm actually privileged to have, somebody from the government sector, that's Nikhil, who works from AIMS, and we've got from private, which is Dr. Mohan, and from international, Dr. Alok. What I want to ask you is, are you really happy with the infrastructure to treat type 1 in our country today? What is really the gaps that you feel that we need to plug to see that the life of a type 1s can be made better? I'm asking this to all three of you because our challenges in the government is different, our challenge in the private is different. And from the outside spectre, Dr. Alok can see what is available in UK and missing in India. He's also an Indian at the end of it. So I want to tease your brains to see that how can we make care for a type 1 much better in our country so that, we bring them to international norms. So let me start with you first. Yeah.
Shall we challenge government industry first?
Yes,
Dr.
that's
Nikhil to respond.
first. Nikhil, would you like to take that?
Yeah, sure. I know. So listen. I think it's important to understand that the key thing for management of chronic disease, as far as I'm concerned, whether it's adult chronic disease, whether it's pediatric chronic disease, is to establish a point of diagnosis, a mechanism for referral, establishing a referral link, and then creating centers which can then specifically look after those diseases. Because to expect that 500 pediatricians in a city like Delhi, all of them will become equipped, skilled, and comfortable to management of type 1 diabetes, it's not going to happen, right? So I think the key thing is to understand that there needs to be identification that this is an important problem, skill a certain proportion of pediatricians and endocrinologists to look after the problem, and then encourage a process that children who are diagnosed are then channelized to those centers as more and more centers develop over passage of time. Because it's the same thing. If you look at a surgeon, somebody who has done, let me use an endocrine example, who does 50 pituitary surgeries in a year and somebody who does 1 pituitary surgery in 5 years, clearly the person who does more pituitary surgeries will be better, would have seen more problems, would manage better, etc. So similarly, we need to create an infrastructure where there is a centralization of care provision, there is basic management done, and then routine stabilization can be done at the place of their usual pediatric caregiver, and then the patient goes back periodically to the center of excellence or center of care, or goes back to them in case of any specific problem. I think a model of care has to be developed more than anything else, number one. Number two, I think for example, the Indian Academy of Pediatrics, the Indian Society of Pediatric and Advanced Endocrinology, the RSSDI, has to then also handhold and strengthen physicians and pediatricians who are going to do this in a proper way. Thirdly is availability and cost, and availability of affordable supplies, whether they are insulin, whether there is monitoring equipment. I think it's important because a lot of patients are not able to afford even conventional insulins, and a much larger proportion are unable to actually afford monitoring equipment. If you're not injecting, so my advice is going to be only as good as if it's implemented, right? I may be giving the right advice, but if a person is not following the advice because of paucity of resources in either getting access to insulin or being able to monitor themselves, that advice is useless, right? So I think for me, those are 3 or 4 things which have to be done at a public sector level. So referral linkages, centers, affordability, and handholding.
So to give you this background, that it's really, I'm happy to say that Dr. Bansi Sabu is extremely passionate about type 1. The RSSD has taken this onus now to create 40 centers of excellence in type 1 care across the country. We have partnered with the pharmaceutical industry through the CSR to make sure that we can distribute free insulin across, and we're taking up this challenge to see that majority of type 1s can get free insulin who can't afford to buy. We've also got a huge district coordinators network, and then to see that at every district level, the district coordinators can pick up children who are type 1s and who cannot get the optimum care, that we are training them. So it's not only just provision, but we are also now educating doctors and at the district level up to there, that we see that they are trained how to handle type 1, because otherwise our centers of excellence will be burdened with, and they will not be able to cater to so many people. So we've got to go out into the periphery and see that we can train more people to take care of type 1s. So we get the expert advice from the centers of excellence, but then at the ground level, these people will have to handhold them and see that they're taken care of. So,
yeah, so Sanjay, that's what I was basically referring to, because you need a linkage between the primary physician and a center of excellence, because we have 700 odd districts. It's going to be very difficult to be able to provide the necessary skills in each district headquarter to the extent that you want to, nor are there likely to be a critical mass of type 1 children in each district, for you to do that. So yes, you need basic training, but you need that linkage so that the fine-tuning of care is done through the centers which are more advanced, and the stable maintenance care is done nearer the house of the individual. So that's
this
the
is
model.
exactly the model that we are actually following. And Dr. Mohan is also part of that entire network. And we've been getting inputs from all the experts in type 1 across the country. So we're trying to build up this huge model of type 1 care, because that's a big model that was a gap that we identified with, and RSSDI should take the onus to make this possible. Dr. Mohan, you want to add something at your what you feel?
So from the private center, of course, ours is a center of excellence. So when I say private sector, I'm not talking about a general practitioner, a general physician. Exactly as what Nikhil said, every MD, he also has to treat COVID, he has to treat malaria, he has to treat dengue, he has to treat diarrhea, he has to treat fevers, he has to treat everything, and then type 1 diabetes also. So while they might be able to do that, most likely he'll get like 2 minutes to spend with a child, and you may not be able to teach insulin, this, that, because he has 400 patients waiting in his clinic. So I think there must be a referral system where they go into a diabetologist and endocrinologist who is able to spend time with, not even all diabetologists treat type 1 children, because they don't even have the infrastructure, they don't have educators, they don't have things, and they are got a big list of people they're waiting. They also refer. So there are people who are interested. So your model, Sanjay and Banshi, of developing centers of excellence, 40 is a good number across the country, and they can then train other people. So that is good. Now, the essentials, picking up the last point, what Dr. Nikhil Tandon said, insulin, no child, this is the 100th year of insulin. And therefore, after having said that, every child with type 1 diabetes needs insulin, then if a child cannot afford insulin, child cannot die because there's lack of insulin. I think there is enough resources. Let us say there are 1.5 lakh children or 2 lakh children with type 1 diabetes in this country. You think a country with 1.4 billion people cannot look after 1.4 lakh children with type 1 diabetes? Many of them who anyway go to government centers where they get it free. I think the private sector can very well do that. And I think a lot of us are doing, I know RSSDI is doing it, all of us in our own individual capacity do that. I have about 400 to 500 children whom we are treating completely free. Not even 1 rupee charge, no consultation fee, insulin is free, tests are free. The continuous glucose monitoring is free, self-monitoring of things is free, glucometers are free, strips are free. Everything is free. Tests are free. Everything is free. If they need admission, that is also free. Okay. So this is our charity. So we all set up little charities and then look after these children, which means that if a child walks in, we don't send them off saying, no, you don't have money, go away from here. That should never be there. And every doctor can afford to treat 5, 10, 20 children, depending on their capacity. Every clinic can do that. And then if you then train the referral doctors also to do to some extent what to do, this can then go on. So I think the first thing is to make sure accessibility, availability of insulin. Once you do that, then that financial burden is taken away. Very sad to say, but there are parents who have allowed their child to die. I shouldn't say this, but have allowed their child to die because they could not get insulin. It's a girl child, and they say, whole life I'm stuck with this child. Finally, this child is not going to get married. Nothing is going to happen to this child, and so better she dies. So they stop insulin for the child, and I've seen that happening. Luckily, over the years, I've been seeing this years ago, but now it's kind of getting better and better with the empowerment of our women. We're getting better and better. That kind of situation should never come. Equitable distribution is very important. I'd like to take, with your permission, Sanjay, Two questions which are there in the thing. Very briefly, I'll answer that. Dr. Subhash Devekar was saying that whom do you send for genetic testing? Although we wanted to make this extremely simple, but then as an academic thing, do we send every type 1 for a genetic testing? Not at all needed. There's no need to do HLA typing and to do insulin GRS score and so on for everyone. If you're doing an academic research paper, you can publish that. But there may be, and this next that follows to the next question by Dr. Gauri Kandla, who is saying that suppose they have a low C peptide, but islet cell antibodies are negative. Then would you think of a non-type 1? A low C peptide is enough to diagnose type 1 diabetes. So if any, in fact, it's more specific than a GAR antibody test, because the antibodies are positive only in about 70% of Indians, 70-75%, 25% of classical type 1s with absent C peptide, with ketosis and so on, don't have antibodies. They're antibody negative type 1. So an antibody doesn't tell you. A positive antibody may tell you have type 1. A negative one doesn't tell you. But a low C peptide, if C peptide is absent, then you can kind of say that it's type 1. Why I'm saying that, I'm not saying everybody should do a C peptide. When they come to me, they come as a final court of appeal. They have come from some 1,000 miles away. They have come and they have brought the child and saying, we have just brought this to you to know whether there's anything else to be done. We don't mind doing anything, any test. Please tell us if there's a 0.25% chance of the child not having type 1 diabetes. Then we'll say, okay, at least I'll do the C peptide. Then I do that. We get the results in 2 hours. So we get the results, say, sorry, C peptide is absent, so this child has type 1. Let's continue the type 1. Very often they leave my consultation straight away. We came only to find that now insulin will continue, they'll say. And they'll go. But just of that one hope, they come. I can't say I want to C peptide for you. I want anything for you. We have the facility to do it. Now, when we start investigating such people, we'll find occasionally somebody who's only on 10 units of insulin, A1C is 6.5, prolonged kind of remission, 2-3 years, still the sugars are not going up. Then we check family history is very strong. Then we do the GAR antibodies, zinc transporter, all the antibodies you mentioned, all negative. C peptide we measure, there is measurable C peptide after 4-5 years. Then we say, can this be something else? That is the kind of person whom we will send for more testing or something, and then find, yes, this child is really not type 1. That's rare. It's not, if you do 100, you might find one like that. 99 may turn out to be type 1, but for that one, that parent is worth it. They are willing to do that. So we should not close the doors and say, no, I won't do any test and all that. But that doesn't mean that everybody should do it. Certainly not. If you don't have the facilities, don't have things, don't worry about it. You must continue the insulin until proven otherwise. On clinical grounds, you cannot stop insulin for anybody because it is dangerous. And therefore, as Nikhil said and others said, if other treatments are being tried, it will be on top of insulin, not stopping insulin. Even you cannot treat, the SGLT2s have come, or something else has come, or metformin has come. Let them all come. But insulin will still continue because we cannot endanger the life of a child. And it's not just with alternative systems. It can be with our own system. You should not try oral drugs in a child unless you are sure that it is not type 1 diabetes. I'll stop.
Look, I'll invite you to make a comment, but I also want you to talk about the parents often want to know that how frequently glucose monitoring should be done in the child for their insulin dose adjustments and to know that how well are they controlled. So while you give your comment, I would like to expand that and say that, okay, how does somebody with type 1 go about doing on a day-to-day basis the glucose monitoring?
Okay. So can I just pick on the previous question, because just something I'd like to share, then I think answer the second one about the blood sugar monitoring. So I think we had a similar situation in terms of, but the India is vast with a lot of different kind of diversity and complex problem, this infrastructure. So, but I think the important thing, maybe we're doing a lot of things, but maybe multi-agency, multidisciplinary, not just doctors only. We need to train other people and involving government and NGO and all those things. But what we did here, I think, and that maybe something may help, and what I think Dr. Mohan did already, creating a network, the local networks, which joins on further regional networks or national. So if I'm living in a village or a town or district, do we have a little network? And that goes to division and that to the region. That something would be very useful rather than really mapping from the national, because that's too complex. But starting being small, making it bigger, I think maybe something we need to think about it. And that's the way we did it, at least in the UK. We started local, small, regional thing. And that really grown up as a country. Maybe something simple, I think we start with, but bringing people together. Because it's not just doctors who can do it, or one hospital or one clinician. We need to bring a lot of people together. So moving on to second question about what do we do, I think generally we say if it's a conventional blood testing finger prick, we suggest 4 to 6 times, depending on what insulin regimen they are on. But roughly we say 4 times if they are on twice daily. But most of children and young people in this country now on basal bolus or multi-dose injections. So we suggest them 4 to 6 times pre-meal and sometime after food, 2 hours after food. But now numbers are going up in terms of obviously Libra2 or flash monitoring or continuous glucose monitoring, but number is still very small. Does that answer your question, Sanjay?
Yeah, I think that's great. Now, since we've got only last about seven odd minutes, I'm going to really shoot some very rapid questions to you for focused answers. Do you think that there is hope by future like islet cell transplants and all those things? So I'm going to ask Dr. Mohan this question. I'm going to ask you to keep the answer brief so that we can fit in some more questions. So what do you think is the hope for the future?
Islet cell transplantation will not be the answer, because nor will pancreas transplantation be that. For a few people, maybe pancreas transplantation, when they have to. First of all, pancreas transplantation by itself is not an approved treatment, because only with kidney usually it is done. But it's being done, and the costs and the follow-up treatment, the anti-rejection drugs that you have to take, we take all that into consideration. Insulin is much better alternative. And where are you going to get the pancreas from? That's the other thing. So that's not going to be the answer. Islet cells, last 20 years, ever since the Edmonton trial, Shapiro's, we have been thinking that it will happen. It has not happened. It may happen in isolated centers. That's not going to be the answer. Will stem cells come? Big hope that it will come. And when Doug Melton's group in Boston announced that now they have a company and they're trying to make this stem cells, long way away. But we can't rule it out that one day we might have infusions of stem cells which would get converted into beta cells. As of now, they're all research procedures. The best thing today would be using technology to control diabetes, either a closed loop system or a pump or a combination of CGM and pump. That seems to be getting you near normal A1Cs like a normal person. Much simpler, less complicated. And I would say that is the future right now.
Okay, Dr. Alok, I'm going to ask you this question because I think this is always something that what would be definite indications for using pumps in our children, because not everybody can afford it, but some of the clear-cut indications that you want to use pumps in your type 1?
Under 5, so when one thing gets diagnosed, we have this something called NICE, which is National Institute of Clinical Excellence. So they create the guidelines, policies for the country. So one of them is any child under 5, nighttime hypoglycemia, hypo unawareness, and I think the clinicians or clinical team feels appropriate, that is taken into account as well. I think, and that's really empowers the clinical team to an extent to say we can make decision which is away from the guideline. But these are the common one. But under 5, more or less, I think going to pump. And now we got around 40% children or young people population in the country are on pump. But it's still around 10% population around CGM or flash monitoring. Now, flash monitoring has come as a part of NHS now funding. So obviously, if somebody is doing 8 times blood test, finger prick, it's cheaper to get a Libra2 flash glucose monitoring than continue with the finger prick in order to improve the quality of life, commitment, engagement. So that's the kind of data we have in the country.
Dr. Nikhil, I'm going to ask you this question. It's a very focused question. So running out of time, but I want you to give an answer to this. How can we improve the ecosystem of care for a child in a clinic, in a specific clinic? So what are the essential components a doctor should have to make the ecosystem for a type 1 care, much better?
This is a very important question. And it's a lot to do with the implementation of care than the science of care, right? I think we've discussed a lot of aspects about the science of care, that you need well control, you need to use multiple subcutaneous injections or pumps, you need to have some form of monitoring, whether it's finger stick or by flash or by CGMS. So I think we've taken care of that in terms of our discussion today. But what about the clinic organization? And I think the first place we need to point out is that it cannot be a physician centric clinic, right? Clinics which are dependent on a single figure, which is the clinician or the physician alone, perhaps are not adequate to meet the requirement of a very complex care situation like type 1 diabetes. So you need additional resources. You need people who can advise them about their diet well. You need educators who will take care of other aspects. You may need some form of counselors who look at clinical psychology. I'm not saying everybody should have everybody full time, but there has to be an access to this human resource available, right? The second thing is how you segregate your clinic. Now, this is it's all. Remember, the biggest problem is that even if you're like 6 years old when you get diabetes, you will still have diabetes when you're 26 years old, right? So it's not care which is going to be given only by a pediatrician or care given only by an adult endocrinologist. There will be a transition of care which will also get involved, right? And that becomes again a very critical part that, and I'm sure Dr. Alok Gupta will be able to speak more to it, that a lot of children who are doing well when they're with their pediatrician, when they enter into adolescence with all the problems of adolescence, and then you ask them to shift to an adult care provider, has significant reduction in quality of care indices. There is attrition of care, there is worsening. You also need to segregate the whole area of, if you have a 5-year-old child being seen in the same clinic where a 35-year-old or a 40-year-old is coming with vascular complications, it can be the most traumatic exposure that the child can ever face, right? So again, some element of partitioning, of firewalling, of segregation. So, and there are several points, and I don't think I'll be able to go through all of that, but I think what I'm trying to say is that there has to be an application of mind over and above the science of care delivery. There is an art of care delivery which is equally important and has to be kept in mind when developing the ecosystem for providing care to people who have type 1 diabetes across their life course. And that is an important thing to understand. It is not a disease which is going to be treated for 2 weeks, 2 months, or 2 years. It's going to be treated for decades. It will span multiple situations, multiple environments, and multiple care providers. That has to be taken into account very, very carefully.
I'm going to ask the last question to Dr. Alok Gupta, and this is actually from the patient's perspective. That if I have a child with type 1 diabetes, what are some of the indicators that will tell me that is my type 1 child doing well and is on the correct road of what he needs to be on? And what would be indicators of bad prognosis or bad care, where he feels that okay, he needs to get more attention. Probably there is something that is missing out on care. So the good indicators and the bad indicators where a type 1 child is concerned from the parents' perspective.
Okay. I think I like to divide into two, keeping holistic view in mind, because some of the indicators are more relevant to the child, young person, and to the parents, which is really, we have not really touched on emotional happiness, so whether they are really leading a good quality lifestyle and they're healthy people, they are not depressed. I think that's a good indicator somewhere we need to fit in, where as a doctor, a healthcare professional, we think about objective like HbA1c, hypos, hospital admissions with severe DK, like DK or severe hypo. So HbA1c seems to be a gold standard, which obviously as a country, we agreed to, I think, maintain around 6.5%, not in millimole per millimole. So that's something I think. So if anyone is maintaining the HbA1c close to that figure, that's a really good outcome. And then there's no complications like DK or severe hypo requiring hospital admissions. These are three yardsticks, at least in children and young population. But can I again really give this message back? I don't want a child who's got a 7% but suffering from depression. I want that child or young person to be happy as an individual and as a family who's maintaining good quality life like his own peer group. And that's really has to be there. And that's where we need to bring that holistic approach in clinical consultations to make sure we got some psychological well-being looked after, or in the team members somebody's helping. I think that really embraces all, and automatically your engagement with that population becomes much better.
Thank you very much, Dr. Alok. I think we've run out of time, but I want to sort of wind up the show with some key take-home messages that we've all had during the course of the discussion in the last 1 hour. And I'm going to just start one, and you could all add your key messages to this list that I'm going to start with. And I want to start by saying that type 1, although not very common, but is there and it's increasing. And for us to see that all our children have best care and they're on insulin therapy, we should not be lured by anyone who promises that there could be an alternative to insulin. So we have to bring the strong message across that all our children with type 1 should have insulin as the mainstay of treatment. No other claims can really be entertained, as has been pointed out during the course of this discussion. With this, I'm going to ask each one of you to add the key messages that you would like to say, and we'll wind up the show. Dr. Mohan, starting with you.
Yeah, so I think all people with type 1 diabetes and their parents should know that 100 years ago, if your child was born prior to 1921, and it's worth saying this because we're in the 100th year of insulin, if the child was born in 1918 instead of 2018, your child would probably have lived for 3 months. The 2 years was almost exceptional, and 3 years was unknown. So a child, it was a kind of one-way traffic. The child died. It's only a question of when they died. And they died horrible deaths. They became emaciated, comatose, and died. From there to a situation when they can live normal lives and do whatever, everything is possible for a human being, was achieved by one and only one, and that is insulin. So think about insulin like you would think about God, or think about your best friend or something, and don't think about it as an enemy which is being injected into your body as a kind of painful torture or something like that. Think about it, something is going to save your life. And from that sense, revere the insulin and be grateful to the discoverers of insulin who made this possible. So be lucky that your child is born in a century where they can live the full span of life, and not like a terrible malignant disease, which could be worse than malignant disease, where the child dies in a few months. So be grateful to that, and always be thankful that you have got insulin.
Dr. Alok Gupta, your message, final message.
My message really, again, to reinforce, unless you got a happy child, young person with happy family, you're not going to get what we want. So make sure we really put, I think, a lot of focus to emotional well-being. And in terms of resources like technology or whatever we are discussing, pump and CGM, they are all right actually. But I've seen the best children with the best HbA1c without that access to that technology. It's a really commitment, engagement, which can't happen unless really they are really happy people who wants to work with us. We can't do their work without them.
Thank you. Dr. Nikhil, your final take?
Just going ahead with what Dr. Alok Gupta said, we are not treating the sugar, we're treating the human being, right? And I think we've got to be very clear about that. That's point number one. Point number two is we need, so I think that there are 3 E's in the management of people. There's erudition, there's excellence, and there's empathy. You need truckloads of empathy out here. Please don't underestimate the need for empathy in managing this situation. Imagine young parents being told that their child who's 3 years of age will require 4 pricks a day to deliver a medicine and 3 to 4 pricks a day to measure their sugar. It is horrible news. You need a lot of empathy. You need to be supportive, and therefore the the science and the art of medicine both need to be invoked in great measure. But still, like a broken record, come back to the last message I want to say, that insulin, insulin, and only insulin as the treatment. If with passage of time we learn that the diagnosis was different from type 1 diabetes, or as discussed during the course of this conversation, there are alternative.
I don't know what happened to him. We lost him. But anyway, I think I would really like to thank all of you for spending your time with us. It's been really very appreciated by all, and I think we've got some very good take-home points, which I'm sure some. Okay, Nikhil is back. Nikhil, please continue.
No, that's also. I just said that unless and until. So please tell everybody that as a starting point, insulin and only insulin. If something else is required or essential, trust the doctor. They will tell you. Don't go running here and there for charlatans and faith healers, because I only see tragedy at the end of that visit.
I think with that very strong message which Dr. Nikhil has brought out, I'm going to say thank you to all of you. It's been a wonderful evening. We've had some great discussions, a lot of points which are practical and relevant, not only from the medical profession point of view, but also from the patient's perspective. We've tried to address in this show. And I think all our stalwarts have done an excellent job. A round of applause to all of them from us, for doing this wonderful job. So I'm going to hand it back to Purvi to end the show and give the final word of thanks.
Sure. Thank you so much. Thank you for your very clear and definitive and loud messages on type 1 diabetes. No one in the world has been able to cure type 1 diabetes so far. And hence, our message to all of you is do not believe fake claims. Please talk to your doctor if you are in any doubt about it. Please do not stop insulin. अगर आपके मन में कोई भी शंका है टाइप 1 डायबिटीज़ के बारे में, तो आप अपने बच्चे का या आपके परिवार के सदस्यों का इंसुलिन नहीं बंद करेंगे। आप आपके डॉक्टर से पूछेंगे, जाँच करेंगे, और अगर आपके पास ऐसी कोई सुविधा नहीं है, तो RSSDI के भी किसी भी माध्यम से आप हमारी टीम से संपर्क कर सकते हैं और बात कर सकते हैं। इंसुलिन बंद नहीं करना है, क्योंकि बंद करने से जान भी जा सकती है। So with that, I take this opportunity to extend a very heartfelt thanks to each of our experts this evening, Professor Dr. V. Mohan sir from Chennai, Professor Dr. Nikhil Tandon from New Delhi, and Professor Dr. Alok Gupta from NHS UK, who have taken this time and effort to be there for this, as they and dropped other important commitments, as they are extremely passionate and they consider this a very important step in clarifying doubts on type 1 diabetes. We thank you very much for your key messages, not only to patients and their families, but a lot of learning points for doctors and physicians themselves. With that, I also thank Dr. Sanjay Agarwal, who is the flag bearer of RSSDI, along with Dr. Banshi Sabu, and this has been their brainchild and their campaign, and we are extremely happy to support it. Congratulations on this fabulous start to creating more and more patient awareness. With that, thank you, audience. Do log in tomorrow. Our campaign is ongoing. We are coming yet again with another set of experts and another set of ideas and viewpoints tomorrow, same time, 7:30 p.m. to 8:30 p.m. Do log in.
I would
Thank
also
you very
like to
much.
thank Bansi for his vision and passion, because I think without his vision and passion, this entire endeavor to bring better type 1 care through the RSSDI would never have taken place. I don't see him over here. I wish he was there. We could have had him on show. But I would still like to acknowledge all the great work that he's done, and for all the wonderful future work that he will continue to do through the RSSDI. So thank you all of you, and good night.
Bye-bye. Good
Thank
night.
you.
Bye.
Have a nice
Thank you.
evening. Good night.
Yes. Thank you.